Yeah.
Hi, everyone. Welcome. I'm just going to wait another minute or so for people to roll in, and then we'll get started. In the meantime, I'm going to put a little message in the chat about some housekeeping, and then I will go over it in a minute as well. Okay, great. So hi, welcome everyone. Thank you for joining today's webinar called An Integrated and Recovery-Oriented Model of Care for People with Concurrent Disorders, Results of a Delphi Study. My name is Tracy Windsor, and I'll be your moderator for today's session. We're excited to share insights from this important research on improving care for individuals with concurrent mental health and substance use disorders. Before we begin, I'll go over a few housekeeping items to ensure we have a smooth experience. So the webinar format, your microphone and camera are automatically disabled, so nobody can see or hear you. You can submit questions using the Q&A button at any time during the session. For engagement and technical issues, let us know in the chat and we'll assist you. Recording and resources, this webinar is being recorded and the recording will be shared afterwards. And we'll begin with a presentation from our speakers, followed by a Q&A session to address the questions that come up. And we'll do our best to respond to all of the questions, but we might not be able to get to everybody's. So I'll turn it now over to our presenters, Dr. Angela Russolillo and Anya Lanz, to begin the presentation.
Thanks so much, Tracy. I'm really happy to be here. I just want to make sure that folks can see the slides and hear me okay. Somebody on the host panel give me a thumbs up. Great. Well, thank you so much for having us. Anya and I are delighted to be here. And I'm actually really excited to be sharing this, the results of this project with you. This has been something that we've been working on actually since early 2022 and 2023. So thanks so much for having us. And I'm coming to you today from Vancouver, BC, and just want to acknowledge that this project did take place on the unceded territories of the Coast Salish peoples, including the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. If you're calling in from somewhere else today or joining us from outside of Canada, please take a moment to acknowledge the lands that you're calling in from. Anya and I will do a brief introduction of ourselves in a moment. I'm just going to provide some brief disclosures. I do receive funding from Michael Smith BC, and this project was funded by an early career award from Providence Research. I don't have any conflicts of interest to disclose. We're going to do sort of a brief overview today of kind of the importance of this particular work in the context of a lot of changes that are happening within our healthcare system, in particular here in BC. I'm going to provide a brief overview, a full description of the model and how we landed on the domains and indicators that were included. Anya's going to talk specifically to some of the qualitative participant comments that we gathered through the second stage of the project. And then I'll provide some closing remarks around policy and practice implications and some conclusions and a link for you to find the full report. We have a number of objectives today. I will not go over all of them, but I'm hoping that what you gleaned from this particular presentation is an understanding of the importance of integrated and recovery-oriented care and why it's particularly crucial for folks who have both substance use and mental health disorders. And then hopefully be able to understand some of the really strong themes and perspectives that came through from people with lived and living experience, as well as healthcare providers, and what the implications are for policy and practice with respect to the current landscape we're in around mental health and substance use care in this province and in this country, and quite frankly, globally. So briefly, I am an assistant professor at the UBC School of Nursing. I'm also a clinician scientist at Providence Health Care. I have many research interests, but largely focus on health service use among individuals who access care and have experiences of substance use, mental health disorders, and other comorbidities. I'm a nurse, and I've been a nurse for nearly 15 years, and I have a lot of practice experience both in acute care community and at the policy level. And Anya, I'll let you introduce yourself.
Yes, I'm extremely grateful to be part of this presentation and contribute from a caregiver perspective. And I have over 30 years of first-hand experience walking along a close friend with concurrent disorder. And in the past 5 years, dealing with more intensively with healthcare professionals and the system as he grows older and needs more complex care. I will be sharing some of my insights and experiences a bit later. And thank you very much, Angela. Back to you.
Thanks, Anya. So I wanted to provide a little bit of an introduction, sort of to contextualize the importance of this work. I've been a clinician in mental health and substance use care for nearly 15 years, and kind of what we see is that for several decades, clinicians, researchers have really tried to understand the sort of complex diagnostic and treatment issues that are posed by the co-occurrence of mental health and substance use disorders. And so these disorders together are commonly referred to as concurrent disorders. And what we see now is that really single diagnoses, so just a mental health disorder or just a substance use disorder, are largely a clinical minority. And we often see folks with several presenting health issues, including physical health, substance use, and mental health disorders. And the interaction of these disorders makes it really challenging from a treatment perspective and places a lot of demands both on the health system, but also challenges for folks accessing care. And so we know that for folks who have a concurrent disorder, they're really at a high risk for a number of adverse outcomes if they don't receive appropriate treatment and supports. And in BC, we're seeing examples of this through increased deaths from unregulated drugs, and particularly folks who have concurrent disorders experience higher rates of overdose than those who have single disorders, so mental health or substance use alone. And so really, one of the challenges that this project was trying to address is trying to get at the fact that we really don't have a care system that's integrated. Care is often described as fragmented and uncoordinated, a patchwork of sort of services that are available, but it's often really challenging for folks with concurrent disorders to access those services, and it creates a lot of unmet needs within that population. And so, despite evidence that people with a single disorder are a clinical minority, integrated approaches are really rare in our current system. And so we really need to start paying a lot more attention to operationalizing and implementing integrated service networks to address a lot of the unmet need. Otherwise, we're going to continue to see increasing healthcare costs and several negative health outcomes within this population. And so we really wanted to be able to develop a model of care that was going to be informed by some of these principles around care integration and recovery-oriented practice. And so the objective of our work was to bring together healthcare providers, people with lived experience, as well as researchers through a Delphi study to develop sort of agreement on the most important elements of integrated and recovery-oriented care for individuals with concurrent disorders. And I'll speak to sort of how we got there and what the process was as we move through this presentation. So you might be asking yourself sort of why this model? Why integrated? Why recovery oriented? And really, it speaks to the idea that the present model, moving ahead too quickly. It really speaks to the idea that the present model of care is just not prepared to meet the challenges. And for decades now, we've been describing our system of care as fragmented and compartmentalized and really lacking sort of the simultaneous and prioritization of both disorders simultaneously within the care system. We often treat one primary disorder first and then consider other things that are happening for a person, but really this integration of care speaks to the idea that all things should be prioritized and that we should be focusing on how to meet the needs of individuals as they identify them through their own personal recovery. So when I'm talking about why integrated care, why recovery-oriented care, Integrated care really refers to this idea of a seamless and coordinated system. So it involves collaboration across multiple sectors, medical health, physical health, behavioral health, mental health, and it's really looking at addressing those holistic needs of the people who are using the service. We know from a lot of existing research that care integration produces better health outcomes across health systems and both quality of life for people. And then recovery-oriented care, I wanted to clarify specifically what we mean with respect to recovery-oriented care, because often this care can be incorrectly sort of synonymized with abstinence-based or recovery, which is not recovery-oriented care principles in the way that they're utilized in this project and have been utilized in mental health care for quite some time. So recovery-oriented care does not mean abstinence-based goals of care. It actually refers to sort of supporting people and their families with personalizing, with adapting to their personal strengths and skills and promoting health and well-being through basically prioritizing the goals and needs that they require in order to live a meaningful life. And so there's a lot of commitment to personal values, personal recovery, long-term continuity of care, and none of which include a requirement for abstinence. So this project sort of evolved in three rounds. We collected information through our Delphi study, which was a survey that we did shared with a select group of individuals who met our eligibility criteria. And so they received 3 separate survey rounds and responded to a number of questions within each round. We included both healthcare providers, people with lived experience, as well as researchers. And we asked them to sort of rate various indicators on a 9-point scale, either being low, medium, or high importance. And we then followed up in a second round and asked questions around people's experiences of care and asked them to rank sort of a variety of different treatment outcomes, individual needs, and health system attributes to get a sense of what types of experiences they were facing in the healthcare system with respect to mental health and substance use services, so barriers, things they'd like to see promoted, and also if they had to sort of select some of the treatment outcomes or individual needs they wanted to prioritize to get them to rank those for us. And so in round 1, participants ranked items and we shared a summary back to them after that. In round 2, they did this more qualitative narrative comments as well as the ranking of various treatment outcomes and health system attributes. And then in round 3, participants re-ranked items from round 1 and round 2, and any new items that we included based on responses. And so this process allowed participants to revise their views and identify items they deemed important for integrated care. And so the results of round 3 ended up being the final model. We did use sort of a more quantitative methodology for assessing consensus. I won't go into that, but if you're interested, it is detailed in the final report. So participants in this survey sort of were represented across largely folks with lived experience and health professional or researchers, predominantly female, age 35 to 44. For health professional folks, they had more than 10 years of experience in their role, and health professional folks had a mix of inpatient and outpatient experiences. We did see some attrition across the rounds. However, we generally maintain sort of a 25% people with lived experience ratio and 75% health professional ratio across each of the rounds. So the Delphi process is a bit convoluted and complex to explain. So I've tried to map this out sort of in a fairly simplified diagram. What I'm showing you here is each of the rounds and the number of indicators. So those are things that we wanted people to rank that were really important to them across certain aspects of healthcare. And I'll get into sort of what the domains and things are, but they were essentially itemized things that might have to do with assessment or care integration or equity in service delivery. And so we had these indicators through each of the rounds. We asked folks to rank them, and then we removed anything that had disagreement. And so the final model ended up being 51 indicators across 7 domains with 19 outcomes that we had prioritized. The main part of the final model was developed from rounds 1 and 3. And round 2 provided sort of supplementary information that's specific to those narrative comments. And Anya will speak to those when we get to them later in the presentation. I am going to provide a bit of a sort of overview of round 2 in terms of what those specific treatment, individual need, and health system attribute outcomes were, because there's some really interesting findings there from this particular project. And we'll talk about the final model following Anya's discussion of the participant narrative comments from round 2. So the items that are in bold indicate that every panel member, so every person who participated in the Delphi round 2, considered that item of higher importance. So things that were really important to folks were improved mental health, access to healthcare services, psychological well-being. In the health system, folks really felt having a safe and timely health system was really important, and equitable was also highly ranked. And so a lot of these things we consider in our own day-to-day care when we're navigating the health system. But it was really interesting to see what was really important to the people, both with lived experience and the providers in service delivery, about what was important to them and how we should really think about starting to shape the way we deliver services and care, because for a lot of folks, safety and preventing harm to people from the care that is intended to help them was a real priority. And other items of health system attributes were less prioritized. And there is a full table in the report that describes in detail the other elements of these particular outcomes. But I wanted to really highlight the sort of the items that people felt were really, really important, and that came through as ranked high above all among all the participant members. And there was in round 2, we also had the narrative comments, and so we asked participants to answer the questions related to their experience of the healthcare system, and through that we actually identified 4 main themes that folks felt were really challenging their access to care. And so high barrier services and limited access to services, a lack of integration of mental health and substance use care, need for trauma-informed and person-centered care, and also the need to prioritize the voices of people with lived experience. And so Anya is going to talk to you about in a little bit more detail about some participant perspectives from each of those themes. I'll hand it to you now, Anya.
Thank you, Angela. I'm gonna just, for context, I'm just gonna come from my own personal lived experience. And I was not part of the study, but I have read through the study and can relate to a lot of the comments that are highlighted on these slides. So for high barrier services and limited access of services, outpatient services are usually Monday to Friday during business hours, and I cannot work or take my friend to appointments unless I take time off, which I have limited opportunities for the number of appointments he requires. There are other barriers that I wanted to highlight that are not necessarily reflected in these particular quotes, but are existing. Families face judgment from societies and employers or even healthcare providers in terms of stigma and discrimination, and that will discourage them or can discourage them from seeking help. Also, many families do not know where to find appropriate services or are unaware of available resources, leaving them feeling helpless and in need for help. Caregivers' burnout is the emotional and physical exhaustion of taking care of someone, which can limit our ability to advocate for our loved ones and have them access the necessary services. And I also want to go into some other areas which are more personal and emotional barriers. One, for example, is that individuals with concurrent disorder may refuse treatment, like in my case with my loved one, and making it harder for family members to access services, and also emotional stress. Caregivers often experience anxiety, depression, or guilt, affecting their ability to navigate the system effectively. And what I really want to stress, which I haven't heard a lot talked about in other studies as well, is family members may not have the knowledge or skills to manage complex mental health and addictions, and especially in their home setting, and therefore we're sometimes left alone on how to deal with the issue outside of facilities. And the next slide, please, Angela. The next are quotes that deal with lack of integration of mental health and substance use care. And I definitely want to highlight the last quote, where there is no clear path from detox to treatment to just support for supports afterwards. And I can say that from my own experience, that there's often no follow-up care for people that fall through the cracks after leaving hospitals. Hospital detox is often a one service only experience, which means no one gives them a phone call afterwards to follow up and see how people are doing in the community. And also the referral process is often broken, since people are often left to themselves for getting the help they need after hospital. And most of the time, concurrent disorders are not treated together. The substance use is prevalent, and in the case of my loved one, as soon as he is getting into hospital or emergency, he has his psychiatric medications for his mental illness taken away and stopped with no reason. And it takes often days and a lot of lobbying to get him back on his psychiatric medications while in hospital. I also would like to say that my loved one has been charged often without any concrete plan of what is next. And then in due time, he has fallen back into his substance use and has never been in an official detox, as those spots are rare and hard to get into. And as family members, community-based services are often at capacity, with long wait lists making it challenging for family to access timely support. And I also would like to say that the economic burden of caregiving can limit access to paid support services. For example, my loved one, who would never pay for counseling or any extra services, I have spent a lot of money getting him help, and never mind getting him sometimes healthy and nutritious food. And lastly, many services do not involve or support family members, where they are left out on their own to advocate on the sidelines or getting help for themselves. Next slide, please. Trauma-informed care and person-centered care is getting a lot of attention lately, and I wanted to just highlight a few of the stereotype and biases that I have experienced and overseen in the care of my loved one. One, for example, he is not motivated to recover, and that is often the addiction is the real problem, overlooking the underlying mental health issue, therefore not receiving a fully holistic care. And what I also see is the bias of young people do experimentation, but older people should know better. And this is a clear shame-based stigma around substance use. I'm certain because he is older, he has received less urgent care and treatment than a younger person, and I have seen that. And he can be seen as a non-compliant or difficult patient, even so it is a challenge to engage them into treatment or manage the symptoms. And as a consequence of these negative experiences, he feels the stigma reinforced and prefers isolation and disengagement with the healthcare system and not seeking the treatment he needs. Next slide, please, Angela. And lastly, prioritizing the voices for people with lived experience. I think these quotes are giving a clear direction that people with lived experience can improve healthcare. In my engagement as a patient partner as well as a caregiver, I have been able to raise issues that would not have been raised otherwise and sit on steering and advisory committees and working groups. I also am a patient partner researcher on a few mental health and concurrent disorder research projects, as well as a co-author on research papers. Here in BC, we have peer navigators and peer support specialists are hired to guide clients through the healthcare system. They work both in hospitals as well as in the community, where they provide real-life insight and emotional support. And policy advocacy by involving individuals with lived experience and advocacy effort can influence the healthcare policies as well as practices, and their stories and perspective can be powerful tool of change. Back to you, Angela.
Thanks so much, Anya. Your perspective is really important, and the context you provided to the participant comments from round 2 really helps us shape kind of how to utilize this important work. So the round 2 perspectives are also highlighted in the kind of final report that we've created. But I wanted to go over sort of how we landed on this final model and what the domains that came through as really important were. And so we landed on 7 core domains that sort of move from some person-centered and recovery or trauma-informed and recovery-oriented principles all the way through how care is delivered, so care transitions, screening and assessment, a large domain focused on sort of health equity components, how to make sure equal access to healthcare. Also ideas around citizenship and choice and community, which are actually really core to recovery-oriented principles, and really often are lost in the current way we structure health system and healthcare delivery. And then domains 6 and 7 were focused more on organizational and individual practitioner training and development, and how we can ensure evaluation and follow-up of sort of ensuring that health systems are enacting these particular principles and indicators of care. So there's 51 indicators, somewhere between 6 or 7 indicators, sometimes more, up to 10 or 11 within each domain. The final report actually provides practitioners with reflective practice questions. So how can I integrate this particular domain into my own practice, giving them opportunities to reflect on ways that they can do so. There's also structured organizational opportunities for change. So how can organizations adopt and adapt to this particular model of care? We provide a number of case studies, useful links, and the full report is available at the web link on your screen, and I'll also provide a QR code that'll link you to the full report. We spent a lot of time thinking through some of the practical ways that we can really influence policy and practice through this particular study and the results of this study, and sort of focusing on developing treatments and services that respond to the needs and realities that people who are accessing mental health and substance use care are facing. And Anya talked from the perspective of some of the themes that were identified, and I'm just going to provide you with sort of a kind of clinical system and policy overview here of what's really important. And so from a clinical perspective, we really want to focus on what the person wants for themselves and what they're actually going to participate in, rather than our own paternalistic views. This was a quotation from a health provider that participated in this study. At a system level, there's a real importance to think about integration of care, integrating teams, working together instead of against each other. We often see in practice at the system level sort of conflicting philosophies of care between psychiatry and mental health provider and substance use providers, and really an absence of acknowledgement of physical health issues within this context. And so focusing on the larger system level integration of services. And from a policy perspective, I think this is a particularly powerful quote from a health provider. early intervention and prevention. We need to be thinking about upstream ways of intervening before we are seeing challenges more downstream. So thinking of social determinants of health and not using sort of the system as a way to respond to crises, but actually thinking of preventative approaches and policies that support the mental health and well-being of individuals in our society. So what might this look like in practice? How would we actually enact some of this in order to make some changes in the current system? Some of these policy and practice perspectives are combinations of themes that we identified and have thought through sort of how we might enact them in a real practice environment. So these are based on what we saw from the data within the study. So offering services beyond business hours. We know for a lot of folks, it's really challenging to access services Monday to Friday, 9 to 5. Offering virtual healthcare options, broadening intake criteria, sort of so that we're not excluding particular folks from any one service. One of the guiding principles of the larger project is that complexity is sort of an expectation, and that we need to understand how to work with complexity and not make it a barrier to receiving services. Because a lot of folks do come with several intersecting challenges that require intervention, and it can be sometimes a barrier for folks. Co-locating mental health and substance use services in the same facilities, co-locating providers. We know there's a lot of success with co-located team-based care, and it supports a lot more integration. We also might want to look at implementing harm reduction, moving away from requiring abstinence to access particular care and facilities. This can be a huge barrier for a lot of folks. Encouraging staff training, reducing sort of reliance on police involvement in mental health calls, and involving people with lived experience in the co-development and delivery of integrated team training, and really prioritizing people with lived experience in determining who should be involved in their community and their family of support, and providing sort of a long-term continuity service delivery plan. Anya, did you want to provide any depth here or anything else?
I can. I would like to after speak to the last two bullet points, which are involving people with lived experience into shaping policies and practices. There are a lot of framework documentation that can aid in the work to include patient partners and family members. And I also like to hone into the fact that leadership in a facility sets the tone of how the facility is run. And if you guide, and they also guide the workplace culture. And if patient advisors are also included in hiring processes, they will aid in shaping a more inclusive and diverse workforce. And I can also see benefits, including patient and family members in shaping the healthcare system, but some thoughts and consideration has to go into it on how to include them and maybe special requirements that they need in order to fully participate. And my many years on varied experiences as both of the patient partner and family caregiver has equipped me with also skills and tools that help me shape more precise advocacy and in turn help my loved one to be more informed. So it can go a long way if you hire one person or get involved some people, and then it has a ripple effect to other people and they get involved as well. Back to you, Angela.
Thanks, Anya. That's important context. Excuse me. So how do we know when we've sort of reached this level of care integration and recovery-oriented approaches in our service system? And what indicators might we refer to know we've reached this sort of level of success? And I'm drawing on something that's adapted here from Leah et al. And really, integration, the key indicators for success of integration really have to do with folks feeling like the health system is servicing and working for them. And it involves people not having to repeat their stories each time they talk to a provider or have an encounter. It involves not having to undergo the same tests multiple different times for the same treatments by different providers. It involves sort of there being sort of centralized access to electronic health records, and sort of the person who's accessing care not being the medium for sharing information about themselves, but having that available as part of the care process. Also, when folks have easy to understand information about the quality of care and clinical outcomes in order to make their own informed decisions and choices in consultation and in collaboration with providers. There's a number of other sort of key indicators, which I really think we need to start including in how we evaluate service delivery. Because right now, a lot of times health services are evaluated based on readmission rates, for example, or healthcare costs, or how many, whether or not there's a capacity of beds. But there's a lot of better ways to evaluate and understand whether we're meeting this threshold of care integration. And I think we could be doing a lot better in the health system at evaluating what is a successful outcome beyond just, for example, readmission rates or mortality rates, because those do not get at the core of what individuals are experiencing with respect to their own quality of life, and ensuring that they have access to the supports they need in a timely and integrated way. So that kind of brings us to a bit of the end of our presentation. I would like to sort of just detail that we have a publication coming up with respect to the qualitative findings from the study. We're really hoping to focus on the development of treatment and services that respond to the needs and realities of people accessing care. And that we would love to be able to see an adoption and implementation of this model, and then including evaluation and feedback moving forward. And so in further work and in further studies, we're going to look for different ways to uncover what works and for whom, because a lot of my research work is oriented towards ensuring people have access to services and understanding ways in which we can improve the health system. And this particular model is one way to adapt service delivery. And we really want to see it expanded and utilized in any capacity where folks are looking for ways to improve service delivery for people experiencing concurrent mental health and substance use disorders. And so I really think that as the need for concurrent disorder care grows, some of these insights are going to be really important for improving the health system, improving clinical practices, and really seeing a shift in the policies that we're using. I'm going to leave you with a comment from a participant that I think really sums up some of the core importance that we've alluded to today from participant findings, which is that folks really want to be kept in mind. People with lived experience should be involved in these processes. And so this particular participant shared that if you want to improve the system, for us, prove it. And don't forget that we're the core of this. We're the very reason you are doing this once it comes time to set up a system. And so I think it's really important for us to acknowledge that system delivery and system access needs to be informed by people with lived experience. And that is a core component of part of the work that we did here to highlight some of the things that folks were facing. And that I look forward to working with Anya and other folks as we move forward in expanding this work to ensure that family perspectives and people with lived experience perspectives are integrated. Thank you so much for joining us today. We've finished within the right amount of time, which is great. I do want to thank all the research participants for sharing their knowledge and experiences and for recommending these recommendations they provided. This was done in collaboration. My co-authors, Michelle Carter and Elizabeth Brindestor, aren't on this call today, but they were integral to this work. And if you are interested in the full report, it is available at that link. And also the QR code is available to you. And if you have any questions for me or would like to get in touch with me, my contact information is available on the UBC School of Nursing homepage. And I'm also happy to take any questions now. Anya and I both happy to take any questions now. I think we have about 20 minutes or so, maybe 15, if there's questions. I cannot see the chat, and maybe I'll stop my screen share in a moment and just let folks, if they want to connect with me, take down that information. but I'll stop sharing my screen so that I can see everyone. And if Tracy or Regina can moderate the chat and the questions, that would be so helpful. Thank you so much.
Great. We'll just wait a little while and see if anybody has any questions in the chat. You're also welcome to raise your hand and we can allow you to speak and you can verbally ask your question.
Yeah, I think you might be able to see, but there is one question from Kristen in the question and answer section, who says, thanks very much for this insightful presentation. What are some recent practice and policy examples that are enhancing the principles of your work generated in BC? So any specific programs that are doing this work well that we can learn from? Thanks.
That's a great question. So I will say that in BC, this type of model is rare. We do have one facility that offers integrated concurrent disorders care. That's part of the provincial health services. It's called Redfish. I am not part of that particular program, but I do know that they do provide sort of a comprehensive integrated service delivery model. I can't speak to whether or not it is recovery oriented in the way that I've described, but there are principles of care integration being exemplified there. I would say there's unfortunately an absence of integrated recovery oriented models. Maybe individual practitioners are operating in that particular way, but I would love to see a sort of a much higher level of investment in this type of care. And it does require sort of a system level change. And that really has to start at the policy level. And unfortunately, I am not aware of any one particular service that's operating to the full extent of the model that I just described. And so I think it's going to be up to a small group of us to see if we can make that happen. But there are a number of principles and care practices, including information from PSR BC and other institutes that have offered a lot of supportive documentation around how to include this type of service delivery model in your own practice and in your own systems. And so I think if there's folks that would like that information, I'm sure it can be shared.
We will wait, see if there are any more questions that come in, but we did post that Redfish link in the chat for anybody who wishes to follow up. People are keen to go back to work, but we do note that there is a lot of thanks in the chat, and I bet you both are not able to see that, but we see lots and lots of thanks from Fabian, Natasha, Nelam, Crystal, Nina. So much appreciation for your research. Great work, helpful to know that it's going on in other provinces. All the best in moving forward. I know it's something that in BC we've really struggled with trying to integrate. And sometimes we make big strides and sometimes we don't.
Yeah. I will, maybe if there's not a ton of other questions, I will mention that we have some related work happening in a research study that we're doing out of St. Paul's that's really focused on kind of complex multi-morbidity presentations as well as care and delivery of services. And so if folks are interested in that, the recruitment for that is also available on our website that I shared the link for. And so if you have people in BC who are interested in participating, please reach out to us. We're actively recruiting for that project and would love to see more folks participate.
And Angela, just to confirm that website is the Care For website?
Yeah, careforccd.ca.
And so we do have one question from Natasha Etherington. What is the most common mental illness you see?
Oh, well, in my particular practice setting, which has largely been in acute care, the bulk of the presentations we see here, and I'll speak to St. Paul's, is people presenting with schizophrenia. We do see a lot of complex psychosis, psychosis in combination with substance use disorders, but primarily the bulk of people who are accessing services in our inpatient setting here are presenting with schizophrenia or some other psychotic disorder. And then following that, we do see a lot of folks with bipolar disorder, and sort of less so we see folks with depression or anxiety in the acute care space, but a lot of our outpatient services also provide that type of care for folks experiencing depression, anxiety, and related mental illnesses. So the St. Paul's environment is a fairly acute space, but I think other sort of urban settings and centers would be seeing similar types of presentations. But we're also sort of in some related work have been trying to understand beyond just sort of the single diagnosis presentation, what are the combinations of diagnoses that we're seeing that folks presenting for? So we did an unrelated project to this one, did a latent class analysis to understand kind of what types of profiles of people are accessing services here, and sort of the main kind of service delivery for folks are people presenting with a polysubstance use plus a psychotic disorder or a primary mood disorder plus or minus a substance use disorder, and then folks who have a really complex presentation, including a number of different mental health challenges, plus homelessness, as well as physical health issues. So we're really seeing the complexity of folks accessing services here shifting. And as I mentioned earlier, it's really no longer a single disorder presentation anymore. It's a number of intersecting challenges and complexity that we're seeing.
We have another question in the chat as well, but I wonder if, do we see any differences in terms of age? So do we have particular complexities for maybe older people who are living with mental illness and maybe younger folk?
I can't necessarily speak to the demographic of participants, but a lot of the folks we do see here are within that 35 to 50. So we don't tend to see a lot of younger folks or a lot older folks. We have different sites for that, but we generally are seeing individuals who are between 35 and 50 kind of presenting in that kind of most complex range of diagnoses.
Tracy, maybe over to you. We have another question there. Thanks, I appreciate that.
Great. Yeah, no, Natasha just said thank you.
Great.
And the other question in the
Oh,
chat.
from Fabienne. Thank you.
Go for it. Yeah, no worries.
Any concurrent eating disorder presentation?
Oh, we have it so not that I can speak to in the paper that I was referring to around latent class, but we do have a specialized sort of provincial eating disorders unit here at St. Paul's, and there are complex presentations there, but I'm not the expert to be able to provide that. If you are interested in knowing more about that, though, I would connect with Josie Geller. She's our clinician scientist and researcher with our eating disorders program.
Perhaps Ida might know that person, just so we can put that person's name in the chat if some people want to follow up. Maybe Angela, you're familiar with the spelling and can help us. Ah, thank you. Thanks, Ida.
It's an active chat on this webinar. Great. Well, thank you so much for having us. It's been a delightful webinar, and I'm sorry I can't see anyone else's faces, but please don't hesitate to reach out. My contact information is available on the EBC profile page, and I'm happy to chat if folks have other questions. And thank you so much to Anya for joining the presentation. Your contributions were really important, and it's been so nice to be able to present together.
Thank
So we
you.
have a last question, if you don't mind, but Chris just asked, is schizophrenia and anxiety considered a concurrent disorder? Please.
Not in the definition that I've provided. So usually we think about concurrent disorder as mental health and a substance use disorder. But that's not to minimize the impact that two mental health disorders may have on somebody. So it's still multiple disorders, just not in the definition we typically use with concurrent disorders. I sometimes refer to those as coexisting or co-occurring. There's different ways to describe that, but the impact is still the same.
Tracy, unless you see other questions and I've missed them, are we?
No, I think that's it. So that brings us to the end of today's webinar. A big thank you to our speakers, Dr. Angela Rusalillo and Anya Lanz, for sharing their expertise, and to all of you for joining us. So a follow-up email will be sent with a link to the webinar recording and also an optional evaluation form. And if you'd like to stay connected, please visit our website at scirehab.ca and sign up for the mailing list if you haven't already. And thanks again for being a part of this important conversation. We appreciate your time and engagement.
Thank you for joining.
Thank you.
Thanks, folks. Have a lovely afternoon and we will speak soon.
Great. Thank you both.
Bye.
Bye.
Thank you.
Bye.